we will move towards our next speakers. It was a panel. I will just introduce you briefly. They were going to talk about the future of robotic surgery in Saudi Arabia. And Saudi Arabian industry is growing in terms of health sector. So I think it will be worth to watch.
Thank you very much, Dr. Musa, for giving me opportunity to talk on this forum. I'm Dr. Tayyab, and I'm CEO of Healthcare Division for Berkeleyme Middle East. The agenda for program today is that we're going to introduce a minimal invasive surgery training program, which are introducing in Middle East area, along with some other innovative ideas. So I have today with me Dr. Najaf Siddiqui, who is the consultant surgeon in Poole, UK, and we're going to have some interactive talk on the significance of minimal invasive surgery and the training opportunities we are going to bring in coming months.
Thank you very much, Dr. Musa and Dr. Tayyab, for inviting me on this forum. It's my pleasure, and I'm really happy to address something and to bring some teaching concept to Middle East.
Minimal invasive surgery concept is very close to my heart, because this is the concept we grown and learned as we were growing and learning the procedure at the same time. This concept came a couple of decades ago. Initially, they did some gallbladder operations, and then they applied it for all the major operations. In the beginning, like everything else, a lot of resistance to begin with, and then it got adopted as it was one of the most significant advances in surgery over the last 200 years, probably, because the concept completely changed from bigger cuts to very small cuts. So keyhole surgery or minimal invasive surgery is small cuts in the tummy, and you can do almost any operation on any organ in the abdomen as well as in the chest, and you can remove the organs which are involved in cancer or some other disease process. The advantage came especially for cancer patients because the recovery was much faster. Smaller cuts mean less pain, and patient mobilized very early. The complication went down, including like clots into the circulation, chest infection, as well as leaks. That went right down. And the other thing happened was they went home much quicker, returned to the work, or in case of cancer treatment, they went to the next step of treatment, for example, chemotherapy, radiotherapy, etc., much faster. So in UK, there's been 2 decades now since we introduced this technique, and after investment of millions and millions of pounds, now we are at a level that almost 80 to 90% patients with bowel cancer are actually approached with the keyhole concept, and 70% of them are completed. And you can tell, even after 2 decades, there is still an area for improvement for 30% patients. Still, we are achieving 70%, and it is continuous hard work. So this is the concept which we want to spread to the rest of the world. And so Dr. Najaf will tell you what are the various approaches of keyhole surgery and how can actually make a difference for the patient, and which one is superior than the other. Yes, Dr. Najaf.
Yeah, thank you very much, Dr. Tayyab, for asking this very hot topic. Because minimally invasive surgery is a hot topic everywhere in the world at the moment. And especially for me, I'm using it for cancer surgery. I've got 2 platforms. One is laparoscopy surgery, and the second one is robotic surgery. As you mentioned, laparoscopic surgery has been there for last 2.5 decades. But still, as everyone says, that there is a room to improve. So we are still improving in laparoscopic surgery. But I think robotic surgery has bring in a new innovation, and it has changed the concept completely. Number one, it is less tiring for the surgeon, but clinically, we have got much more control on the instruments as compared to laparoscopy. And then above all, we have got curved instruments, which has got 360 movement, and you can approach the narrow spaces much more better than laparoscopy. So in our scientific language or a colorectal cancer language, male pelvis post chemoradiotherapy, that is the patient nobody wants to operate. But with robotic surgery, I think everybody would be happy to operate on them. You have got excellent view. You have got the instrument to work in those spaces with much better clinical and oncological outcomes. So both concepts are there, but I think starting off, one should start off with laparoscopic surgery, get their concept better, and then hands-on to robotic surgery, even though the literature or the evidence says that the open surgeons can adapt robotic surgery much more quickly as compared to laparoscopic surgery. If one has got the money and they have got the opportunity, they can straightly go on to robotic surgery, but laparoscopic surgery can give the same outcomes as robotic surgery. So clinically and oncologically, there is no difference in the results, but we have got few advantages as surgeon in robot.
That's a very good answer. Yes, I completely agree with Dr. Najaf that the robotic surgery actually has revolutionized the system again once more. So 20 years ago, we were talking about minimal invasive and nobody was adopting it. But now we've gone to robotics. So that has changed the life completely for the surgeons. So less tired. And just to explain the point which Dr. Najaf mentioned earlier, he mentioned about rectal cancer surgery in male pelvis. This is one of the most nightmare operations for a surgeon. Most difficult, had the worst results 2 decades ago, and that significantly changed with these two techniques and with the operation which we used to find miserable now has become enjoyable, and the results have significantly improved. And so that's really a big change. And I'm sure the future surgeons coming in the next decade or so will have very modern robots with very slim and with a lot of much cheaper as well. And that probably will become a standard of care in coming few years. So, Dr. Najaf, we want to introduce minimal invasive surgery in Middle East. We want to transfer our skills down to the people there. What do you think is the best way of doing that? What is the concept?
So, Dr. Tayyab, I'm very keen to go towards Middle East, especially to Saudi Arabia. Number one, for religious reasons, and number two, I'm very keen to explore this area for personal reasons as well. But I'm sure Saudi Arabia or the Middle East have got wonderful surgeons. They are already doing these surgeries. But the concept of standardization and the modular approach needs to be out there. As we can see from our previous practice, published papers, and the evidence that the modular approach and the standardized technique can bring better outcomes for the patients. So whatever technique they are doing, if we can standardize that technique and spread across in different regions, then I personally think they would become better surgeons. They would have better and predictable outcomes. So standardization is the word which we need to spread out from teaching point of view. So
I agree, Dr. Najaf. I can't disagree on this at all. Because we learned as you were growing in our training that actually everybody was adopting their own technique, and now suddenly, not suddenly, it came over the experience, and now we have decided that actually. It's operation done in the same way on every patient actually produces better results. And this concept actually helps you teach someone. So if you're inventing a new operation for every patient, that means you actually can improve this for the patient. So when you say modular approach, so what have you done to the operations? Have you divided them into steps one by one, and how do you assess them against their competencies?
So, Dr. Tayyab, I'm sure because we both had the same training from same people, and we went through the same concept of teaching and training. So we divide the operation into different modules or different steps. It's easy to remember, easy to learn, and I think it is easy for the trainer to teach as well, because you're not concentrating on the whole operation and haphazardly you're going fast or on few steps and then slow on few steps. So you decide beforehand or on the day that we have got 5 steps of this operation, and we are going through 2 steps today. And then those 2 steps can be taught in a better way, because a trainee and the trainer will be concentrating on those 2 steps. So this is just an example that we modify or break down the operation into different steps and then teach them step by step in a modular or a standardized way or a modular approach. And then once they are well versed with all the steps, then they will perform the operation fully. So it is a breakdown of the operation into different steps, as you said, in layman language or a simple language.
Okay, so that's what we wanted to highlight, because and then we decide which based on the competency level of trainees, that how do we approach. So it's individualized approach. So basically, when we get a group of trainees which we need to train, we actually assess them and divide them into categories. This person is starting keyhole surgery. This person actually is the intermediate level. This person is actually doing advanced operation. He just needs to polish his technique and make it standardized. So we make one-to-one supervision and training for these individuals and take them from competency levels higher up. So we have special forms where we assess every module, and once they reach a certain competence level, they are awarded a certificate for the completion of training. We normally liaise with local universities and also provide as extra diploma for the same training, as well as providing them diploma from European Institute of Minimally Invasive Surgery. So
one final thing, Dr. Tayyab, because we have talked about all other things about laparoscopy and robotics. If somebody would ask you about the cost effectiveness of robotic surgery over laparoscopy, or the other way around of laparoscopic surgery versus robotics, so anything for the audience from that point of view?
So if you ask me to choose between the two, I will choose robotics because of the obvious reasons. It's a much enjoyable operation, less tired, and obviously better for the patient. Cost-wise, if you compare the cost during the patient hospital stay and during the 30 days period, so maybe the hospital and operative cost may be higher in robotics, but actually long term there are definite advantages which are actually much more beneficial. For example, we clearly see in patients with the rectal cancer, cancer in the back passage, in the difficult areas, we see the anatomy very well. We don't damage any nerves, and actually the functional outcomes afterwards are better, and that means in the long term they have an advantage. So if you ask my choice, I will go with the robotic approach. In terms of cancer outcomes, there's no evidence that one of them is superior than the other at the moment. But as you mentioned before, the new techniques are coming in, and actually they go with robot, and that means there's a better chance you can pick the lymph nodes, the glands, which are where the cancer spread, and you can pick them and take them out at the same time as a cancer. So there will be superior results coming in immediate and long term.
No, I completely agree with you, because but I've done some work on the cost analysis between laparoscopy and robotic. So initially, yes, I would say a trust or the hospital has to spend some money to buy the equipment. But in long term, after 40 cases, the cost becomes same. So the operation cost itself is same for the robot and the laparoscopy. And another thing which need to be highlighted about robotics, from 1st of November, the Da Vinci company has extended the use of the instruments. So that will bring down the cost a lot more. And maybe for people who are doing regular robotic surgery, the cost analysis between laparoscopy and robotic surgery, the robotic cost will be lower than the laparoscopy. So if it is a hype in the market that, oh, robotic surgery is very expensive, but I think on long term, robotic surgery would be comparable to laparoscopic surgery from cost point of view.
And you're talking about based on the most expensive robot in the market.
Yes.
Soon, you're going to get cheaper robots from every company, and then cost probably will become even less than laparoscopic surgery, I think.
Yeah, you're right. You're right.
So just want to ask you the concept of MDT, because we, as a cancer surgeon, we really feel the concept of MDT needs to go out. It is a standard practice in UK for cancer patients, and they get the best outcomes. Can you please tell me that how do we address that? We have integrated that as a part of our training, and we are going to train you along with surgical technique. But can you please clear the concept of what MDT is and what is the advantage?
Yeah, Dr. Tayyab, you're right. MDT is one of the most important concept which should not go unnoticed. So as you and me both knows, when we go out to train other people, we have seen in a lot of places there is no concept of MDT. And when there is no concept of MDT, then they don't have a control on the patient outcomes and the patient management. So to explain this concept, so MDT is a multidisciplinary team meeting in which the surgeons, oncologist, in brackets, cancer specialist, gastroenterologist, radiologist, who reads X-rays, they sit together, and including the pathologist, and then they analyze the patient, or they discuss the patient fully, including their specimens if they are post-op, including their radiology if we are planning for an operation. So the main concept is that all the team members are sitting there to make a better management plan for the patient so we can have better outcomes. So we are all sharing the opportunity to make a plan for the patient. And we have seen from our experience that the patient outcome has become better after the introduction of MDT.
I agree, Dr. Najaf. I think this is the second biggest change over the cancer care over the last couple of decades. You remember not long ago, a couple of decades ago, the surgeon used to think they're like gods, they will treat anything. Yeah. But we realized actually this is not true. So, and since we realized this and standardized this in UK practice, you can see the result. So cancer outcomes after bowel cancer has just significantly improved. Along with the other specialties. Now, this is a standard practice all over the UK. And I think is one of the biggest messages we are going to spread out along with our trainings. Can you please tell me we are going to provide trainings to the surgeons, but there's a concept of training the trainers. What happened to the very advanced surgeons who are consultant level? They know how to do the operation. So what advantage can they get from our training?
So I think, as you mentioned earlier, that those surgeons, once they have been signed off that they are fully trained, then they can go through a process of called training the trainer concept. So there is a course which you and me both provide, and we train them in how to train other people. So it is a 2 or 3 day course, depending on what course they want to opt. And they will be certified from a university or from one of the testing body who will give them a certificate that they have been trained to be a trainer. And then they can spread that training to their local level or national level and train other people. So it will become a chain. So we don't need to train the whole region. We just need to train, let's say, a few people who can further train the other surgeons in their area.
That's perfect. So this is will be a perfect package that not only we will train the trainees, but also train them to a level that they can train further trainees in future. So that is a very, very good concept. Apart from that, please tell me, because how will we know that the training we have provided to our trainees has actually resulted in a better outcomes in terms of cancer survivals, complication rates, etc. after we have trained them? So what is the way to assess them?
So Dr. Tayyab, as you and me both did the same thing, that we collected our cases and we are still collecting our cases with their clinical outcomes and oncological outcomes. So we always ask our trainees to maintain a data sheet or a logbook and collect all the data about their patient and their length of stay, any complication happens, and what was the staging of the cancer, and how they are doing in their follow-up. So they need to do or keep their database for a few years to see how the patient is doing. So, and then they need to look at the rate of morbidity, mortality, any cancer reoccurrence or the cancer coming back in few years. So these are very important outcomes which everybody should measure. And we are, even if we are still measuring, we will expect our trainees to measure those outcomes, because that will lead to a better teaching model where we would know that how the students are performing or how the teaching is spreading to different people and what their outcomes are. And we know from our experience that all the trainees which have been trained before, their outcomes are not inferior to us or not inferior to their trainers.
That's correct. So this is what we want to do. We want to not only train, we want to see actually that if that made any difference. So we encourage to our trainees to actually provide the data, and we can and we have actually written and published papers on our trainees, and that has actually shown that trainees have the same results as their trainers, which is what we want to achieve in the end. So
I'll show you an internal clip of a robotic surgery. This is a 43 years old male who had a chemo and radiotherapy for rectal cancer. So this is just a short clip for introduction. And this will show the anterior dissection of the rectum, which is the most difficult part of the rectal cancer surgery. So I'll show this clip. We are making an incision in the peritoneum or peritoneal reflection from where the rectum starts, and we will go down into the pelvis, which is the most difficult part of colorectal cancer surgery. So the disadvantage of post-chemorad or radiotherapy is even a drop of blood will make it completely red. You can see the right nerve falling back. And now we will come anteriorly. So we are separating the rectum from the seminal vesicle and the prostate. So this plane will develop onto the denonvalvular fascia, which is the fascia covering the prostate. This is the left lateral side, and you can see the nerve which is falling back. And you can see that because of the angulated instruments and the stable camera, we can see all the angles very easily. So this is the denonvalvular fascia in front of us.
So thank you very much, Dr. Najaf and Dr. Musa, for being here and inviting me in this forum. Hopefully we will be with you in more sessions and live sessions, webinars, etc., and we can explain it in a better way and take question and answer session next time. Thank you very much.
Thank you very much, Dr. Musa and Dr. Tayyab, for inviting me on this forum. I wish you all a good luck, and good luck for the training and teaching and innovation in Middle East. Thank you very much once again.